Okay. Just somebody, when somebody comes in wheezing, I say, oh, hell, that's airway. That's obstructive. I just go down and answer the question. So you guys want to read the rest of the story and all that. I don't. They ask me a question. I already know the answer. Once I figure out if it's restricted or obstructive, I'm out. Okay. Only if they say what disease is it, okay, fine. Then I got to keep reading to figure out what disease it is. But if they're asking me some physiology of the disease, folks, you don't need the whole vignette for that. All I got to just figure out, is this restricted or obstructive? Get out, click answer, and you keep moving. You already got the point. Okay. All right. So anyway, oxygen has difficult time diffusing across. Oxygen will build up, causing free radical formation. When you have all these free radicals building up, what organ are you worried about, Lillian? The brain. It's always about the brain. Don't ever forget that, folks. It sounds like it's a new answer. No, it's still about the brain. All right, in the brain, the most fragile vessels are the vessels right along the medial wall of the two lateral ventricles. Anybody remember what that was called? Avi? No, lenticule striatus is an internal capsule. All right. The germinal matrix, the number one cause of intracerebral hemorrhage in premature babies. Just so you see, it's all connected. That germinal matrix has real fragile vessels. So as soon as free radicals start flying, pierce right through the vessels, and you start bleeding. And because you're bleeding right along the midline, which fibers are right along the midline? Armando. Yeah, legs. Remember spastic diplegia. Why is that the most common cerebral palsy in America? Because the leg fibers are taken out. Everybody understand that? All right. This way you keep connecting things together is not something new, because now you know how to connect things together. All right. So that's one. Number two, it damages the retina. The retinal arteries are real tiny too. So you get retinopathy of prematurity, or ROP. Retinopathy of prematurity. Free radical damage. So how can you decrease the incidence of these things? By just giving them a certain vitamin, Zena? She forgot, Hannah? Vitamin E is therefore given to all premature babies in America now. That's a protocol. All right. So again, I don't want you to just memorize the protocol because you saw it in the book in the protocol, but you actually know why they started that. If you can absorb a lot of these free radicals, guess what? Decrease this incidence, decrease the blindness incidence too. Light must hit the retina by what age, or else you're blind for life, Zena? How long do you have to hit that retina? So up to 3 months of life. That's it. After that, the brain just shuts down the retina. No more information coming in. Doesn't matter what you do after that, they won't get vision. This is actually what took Stevie Wonder's eyes, because back then they didn't know what to do. All right. So restricted lung disease, known to man. I'm just summarizing it for you. So follow along again. This is the third or fourth time. I expect each one of you to be able to go through this if I ever ask. Okay. They have poor compliance. Now you know why. Alveoli collapse. They have trouble breathing in because you need to breathe in to pop the alveoli open. They have poor diffusion because alveolar collapse. They have increased AA gradient. The big A is alveolar, small a is arterial. So that's oxygen in alveolus minus oxygen in arterial. Well, the big A has the most of the oxygen, is hardly getting to the other side. So that's why they say large AA gradient. So anybody with a diffusion problem has a large AA gradient automatically. You should be able to visualize that now. And then there's the blood gas we just derived. PO2 is low because it's having a hard time diffusing some. The baby or anybody else starts breathing faster, so PCO2 goes low, and therefore pH goes up. That's what I'm saying, folks. Talk it out so you don't just memorize these numbers, and then after a while, you forgot how we even got here. All right, because then you get confused on the data exam, and now you can't remember, what was that blood gas again? See, that's memorization. All you gotta do is talk it out. You'll come up with the answer again. They develop a secondary perfusion problem because hypoxia constricts the pulmonary vessels. Now you know why. Low energy state from hypoxia, low volume state from pulmonary hypertension. Okay? And they all die from heart disease, right? But it's called cor pulmonale, because cor pulmonale, Ida, lets me know is right-sided heart failure. Because remember, 90% of heart failure is left-sided. So that's why they came up with a new term. But notice the concept is still the same. You still die of heart failure. That's what I mean by concepts and patterns don't change. They keep changing the words around, but the pattern is what you ought to try to make sure you understand, not words, because they'll change the words. Okay? So if they say heart failure, they're talking about left-sided heart failure. If they say cor pulmonale, then they're talking about right-sided heart failure. Okay? And if you have right-sided heart failure, Michael, what's the only treatment we have for that person? Let me see if Justin can remember. He remembers that after I say Justin. Michael says what? Fluids is the only treatment for right-sided heart failure. So you see, because we had electron heart failure, you already know how to treat all of them. I don't have to give you a new lecture about how to treat it. You already know how to treat it. Okay? So all the restricted lung diseases have right-sided heart failure. You already know how to treat all of them. As far as heart failure, only one thing works: fluids. Drugs don't work because 85% of drug keeps going to the left side because that's where 85% of blood flow goes. There's no way to force it to go to right ventricle. Any questions on restricted lung disease? Cool. Highly membrane disease. Yes, I understand. Why is it fluids for the right-sided heart failure? Anybody know how to explain that? Nobody learned it. All right, Michael. No, both sides have volume problems. Yeah, feet are swollen, liver swollen, everything's swollen, but it's not that. All right, Jess? Well, let me make it easier for you. It's because when you got right side of heart failure, I cannot drown you with fluid. Left side of heart failure, any fluid I give you will drown you. Left side of heart failure, any fluid I give you piles up in the lungs, you will drown. Right side of heart failure, any fluid, excess fluid I give you just goes to your legs. No harm done. All you're doing is maximizing Frank Stalling forces, Jess. Frank Stalling forces says if you have more EDV, you have more cardiac output. Because if that blood goes in the lungs, the left side is fine. He'll take it and pump it forward. So fluids. And for the step 2-3 people, they say take wedge pressure all the way up to 18. That's when they start getting short of breath. But beneath that number, there's no pulmonary edema, and they're doing just fine. They're getting more cardiac output because you're pumping more blood through the lungs. So fluids cannot kill you if you have right side of heart failure. Fluids can kill you if you have left side of heart failure. You understand, Rachel? You understand, Miguel? Everybody else understand? Okay, just so you understand, why is it just fluids? There it is. Keep it simple, easy to remember. Yes, sir.
So the problem was because you had the right side thing, you never got enough blood to the left side.
Yeah, you never got enough blood to the left side. So get more blood to the left side, guess what? More output. Yeah. Okay. All right, but that can only go for so long because the right side will eventually finish failing and then the person dies. But at least you make them feel better during that time. All right, complications of highly membrane disease or any restricted lung disease are as follows. As compliance drops, Karina, you follow me for this. As compliance drops, the need for pressure support rises. This is how to remember that if you put somebody on a ventilator with restricted lung disease, you have to add pressure support. See? That way we don't have to read about any of them. Because now I know why we're always doing that. Well, there's 3 types of pressure supports, Karina. One is called continuous positive airway pressure, CPAP. That means it's blowing air through your nose into your lungs. That's continuous. What happens when you inflate a balloon that doesn't want to inflate and you keep it continuously inflated? You see a problem with that, Karina? What? It says continuous. It's going to keep it inflated. It's going to pop. Highest incidence of pneumothorax. I remember when I was a resident, man, almost every room in the ICU that had a pneumothorax that had a tube in their chest. And I didn't know we were the ones causing it, but this was all we had at that time. Back in the 80s, this was the only thing that was available. And it was just popping lungs everywhere. So then somebody came up with a different one. It was called PEEP, positive and expiratory pressure. PEEP is the same thing as grunting. We all grunt. What you're doing is, rather than letting all the air come out, you blow some of it back real forcefully and alveoli open up. That means for the next breath, it comes easy now. All right, that's PEEP. But what is the problem you see if you keep forcing a balloon open that doesn't want to open? It's gonna pop. Pneumothorax, just not as high as CPAP. Okay, just so you understand. Why do we keep coming up with new techniques for this? Now we use BiPAP. BiPAP is bi-level positive airway pressure, Ashley. That means you can decide when you want pressure to be applied. For restricted lung disease, do you want pressure to be applied during inspiration or expiration? Only during inspiration. Everybody clear about that? So this way you take the pressure off during expiration. And now the balloon is not constantly open. Lowest incidence of pneumothorax. I mean, I'm telling you, back in the 80s, every room had a chest tube. Now, again, I noticed patterns, but back then I sure didn't understand it. So why's everybody got a chest tube in? How was it? Everybody's got pneumothorax. I didn't understand that CPAP was just inflating balloons and keeping them constantly open. And the balloon is already stiff. It doesn't want to be open. It's going to pop eventually. Any questions? All right, now they say before you put somebody on a ventilator, because we know if you put on a ventilator, you're going to have to use one of these. They say try doing non-invasive. So it's called non-invasive positive pressure ventilation. NIPPV is now the standard, folks. There's a lot of questions now I'm seeing on UWorld testing. Make sure you know that. So when somebody requires ventilation, we used to just put them on the tube and put them on the ventilator. Now they say, no, try this first, because you put it with a mask. The benefit of that, not only that you can still give BiPAP through it, but you avoid ventilator-associated pneumonia. Remember, germs live in there. Yeah, especially like Legionella, water is going through there. Well, guess what? We transmit infections too. Okay? So you cut down the number of pulmonary infections due to pneumonia. They call them VAP, ventilator-associated pneumonia, if you use non-invasive. So watch out now. I've seen a lot of questions. I was about to pick ventilator. I said, ooh, and okay, that's right. And I switched, and that was the right answer. Had I picked a ventilator, I would have gotten wrong. Just so you guys know, it's switching, but it's a good switch. Based on what I'm seeing, the literature says that is the best way to keep, ventilate somebody who doesn't need to be on ventilator long term. Because somebody who collapses, you don't know, maybe they need a ventilator 1 or 2 days. Well, you don't want to put them on a ventilator and then run into other problems. Now they get pneumonia by the second day. Okay, now they got to stay on the ventilator for another 7 days. All right, so you see, folks, over time, we was chasing our own tails, and we didn't know. All right, as diffusion decreases, the need for oxygen increases, right? Because you got this fibrosis or membrane in front of you. Diffusion decreases, you got to give more oxygen. More oxygen means more free radicals. More free radicals means more damage. More damage means more membrane. More membrane means less diffusion. Everybody see the vicious cycle? And that's why 60% of these babies used to die on a ventilator. Die because their lungs were so heavy with this membrane. It was so thick that even a ventilator could not push their lungs up. So if the ventilator can't move for you, you can see the baby's not gonna move it either. And that's why they would just die on a ventilator. 6 out of 10. And prematurity still remains the #1 cause of death in the first month of life. Neonatal mortality rate, still based on prematurity. Well, somebody came up with a jet ventilator. They said, what if we strap a jet engine to a ventilator? What difference would that make? Well, let's see. If you walk into a room, someone in a jet ventilator, all you it's going so fast. Also, I hear the whole time. Before you could hear, not in here. With a jet ventilator, all you is breathing for you 250 breaths per minute. It's breathing at a rate that you and I can never establish. 250 breaths per minute. So what are you really doing? Here's the net result. I'm really just pushing in 10 molecules of oxygen. I'm just giving you a number. 10 molecules in there. In a fraction of a second, suck 9 of them right back out. 10 in, 9 out. 10 in, 9 out. 10 in, 9 out. So what am I really doing? Single file of oxygen molecules just walking in there like this. That's it. What are you doing? Avoiding free radical formation. So without free radical damage, less membrane, less diffusion, and mortality dropped 30%. It went from 60 to 40. So when you see that mortality rate in the literature, it sounds, oh my God, that's high. Well, it is high, but it used to be 60. At least we got it down to 40% now. Okay, but they'll ask you how jet ventilator works. The books always say decreases barotrauma. That's what they're talking about, free radical damage against the membrane. And that means less of highly membrane production. Somebody decide, hey, you know, if jet ventilator works for RDS, why don't we use it for ARDS? That's the same disease in adults. So let's talk about that. ARDS is just the adult form. However, the problem here on them is that you've got increase in permeability of the pulmonary vessels, allowing fluid and proteins to leak out and wash away your surfactant. See, now you're back to the same place as RDS, no surfactant. But they love to ask, what is the underlying problem? It's not no surfactant. Surfactant was there, but it got washed away. So it's increase in leaking or increased permeability, however they want to say it. That's what caused no surfactant. Everybody understand the difference? Permeability is not the same thing as Lack of surfactant is RDS. That's why there's collapse. But at ARDS, there's collapse is secondary. That means you have leaky vessel, fluid and proteins leak out, wash away the surfactant, and then they collapse. I know. Sepsis is the #1 cause of ARDS, and trauma is #2. Any questions on that? So somebody came up with the idea of using jet ventilator for ARDS. What I found amazing was who actually came up with the idea. It was not the pulmonologist who did the first study on RDS. You know who came up with the idea? The respiratory tech, who's not a pulmonologist. He made the connection. And then they did the study and he was right. It should work on them too. So guess what? Then he realized it should work on any, you can use on any severe restricted lung disease. See, that's connections versus you got to wait till people have a bunch of other diseases to see if it works on them too. No, you can make the connection for yourself and be way ahead of the curve. Okay, so the tech saved more lives than the pulmonologist who's supposed to know all this stuff. Okay, all right, so remember that, ARDS. Jet ventilator works for them just like it works for any restricted lung disease. So anytime somebody has restricted lung disease, you want to use, again, this positive pressure. We know they're all going to need it, but BiPAP is the safest. Everybody follow me? And if you think they're only going to be on ventilator for a couple of days, NIPPV is better. Also avoids pneumonia on top of the problem. Okay? And then if the disease becomes real severe sarcoid, severe histo, whatever it is, then use jet ventilator. Any questions on that? Another thing you can use is that the lungs are so badly damaged and you want to give the lungs a break. Let them heal up and not have to work for you for a while. Then we use something called ECMO. Extracorporeal membrane oxygenation. What that means, Anna, is that rather than let your lungs oxygenate for you, we have a tub over here that'll oxygenate for you. I mean, but that means we got to hook up a tube to your aorta and a tube to your inferior vena cava. That means the blood is not going through your lungs anymore. It's going through this tub over here. It allows your lungs to rest up. So in ECMO, there's two types. VA, that means a vein is attached to an artery, or VV, a vein is attached to a vein. When do you need either? Well, for your lungs, I want to attach an artery to a vein. I want to attach an aorta to the vein so it bypasses the lung. So VA is when I want to rest your lungs completely. VV says I want to bypass an entire tissue or organ. So I attach one vein to another vein, so it never went through the tissue at all. It just comes right back up to the to that machine, okay, and bypasses that tissue. So if you got like liver failure and we want to rest your liver, or GI failure and we want to rest your GI, you can. So VA is the most commonly used because you can attach an artery to a vein and that way you bypass the tissue altogether. All right. That's just extra information for you guys because I didn't use to talk about that till this time. All right, so anyway, complications of doing what we just said we're about to do, Angie. More pressure support can lead to pneumothorax. Now you know how and why and which one has the highest incidence. This is where you're not guessing, okay? So what happens when you get a pneumothorax? You got air outside the lungs compressing your lungs. If I compress your lungs, Cesar, it then compresses your heart. It's the same physiology as a tamponade. And that's why, remember tamponade? Kussmaul sign, no surprise. Tamponade, remember? Pulsus paradoxicus. So you got to remember what they were, though, because they'll describe it. They're not going to just say the word. Kussmaul sign, increased JVD on inspiration. Pulsus paradoxicus, exaggerated drop in pulse or blood pressure with inspiration. It means there's hardly any blood coming in on the right side. That's all it means, physiology. Loss of pulse and blood pressure, then you become cyanotic because no blood has moved through your lungs in a while. And then Hammond sign is when the pneumothorax is so large, I can actually feel bubbles underneath your skin. I press on your skin, I feel crunch, 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 crunch. They'll call it subcutaneous, they'll say crepitus, air bubbles. Hammond sign, evidence of a large pneumothorax. Let's look at pneumothoraces. There's two types, spontaneous and traumatic. Why are spontaneous pneumothoraces so common in women, Josh? Muscle relaxation due to what, Josh? Thank you. Let's just say estrogen connection. Come on, baby. That's how it's done. See? So look at my hand. Muscles relaxing. What are they doing? Yeah, if you're like opening up for no reason and one day they pop. Spontaneous is so common in women that whenever they get chest pain, sudden chest pain, PE is number one, spontaneous is number two. MI is way down the list. It's not MI. They pop blebs all the time. What about the tall, thin male? Who the heck is that guy, Gloria? Who? Yeah, Klinefelter, who has an extra X, so he has extra estrogen. See that? Same physiology. So you're not just memorizing. Don't memorize, folks. Connect it to something you already understand. And therefore, if they come up with some strange disease, as long as you see the same thing happening, you say, yeah, why not? Instead of thinking you got to be sure of everything. Okay? All right, some hands are up here. Oh, my video's up.
Excuse me, I can't see you. Okay.
You want to see me, Mabel?
Yes.
Oh,
I can see you
no
now.
problem. No problem. It just goes out from time to time. All right, Abdullah Khan, you have a question?
Yeah, a little while ago when you were talking about the jet ventilator when it's used in ARDS, can it also be used for antitrypsin deficiency?
It can be used for anything restricted lung disease physiology, sir, including alpha-1 antitrypsin deficiency.
And the other thing I wanted to ask was the ECMO, the venous one. Can that be used for like compartment syndrome to save the limb?
Let me see. Yeah, from one vein to another vein. Let me see. If you go from a vein to a vein, what you're doing is stopping from even going up to the heart. Yeah, you can use that for compartment syndrome. So, or we use it primarily for when there's heart disease and you want to rest the heart for a while. Then let the machine do all the pumping and the oxygenating.
Okay, thank you.
Follow? Yeah, but at least now you're starting to see it. All right, so spontaneous pneumothorax, again, women, and is this all estrogen connection, folks? Tall, thin male is Marfan's and Klinefelters, but they have weak alveoli too, so they're overinflated. Trauma is number one, stab wound, rib fracture, gunshot wound. Kind of explains itself, so that's easy. If you get stabbed on the left side of your chest, that's a bad day because your heart is on that side. Number one cause of death is tamponade, followed by pneumothorax, then hemothorax, in that order. So that means when they say, what's the next step of your management, is based on tamponade is going to kill them first. You better take care of that. Remember, what's going to kill your patient first is what they expect you to be managing when they say, what's the next step of your management? All right. You get stabbed on the right side of your chest, lucky day, relatively, that is. So now your heart's protected on the left side. It's just pneumothorax followed by hemothorax. At least tamponade is off the list. If you have an asymptomatic pneumothorax, that's usually a female who popped a bleb. And when it's when it's less than 25% occupation, this is a number that they want you to know. So less than 25% of the pleural cavity is occupied by that air bubble. The answer is do nothing. So we see lots of times when you do an x-ray on a female for something else, and radiologist says, oh, she's got a spontaneous pneumothorax of 17%, which means 17% of the pleural cavity is occupied. Then you know, under 25, do nothing because she didn't even come in for that. But if the person is symptomatic at any level or is more than 25% occupation, you have to put in a chest tube. Just know you know criteria. But what about this needle thoracostomy? If it's more than 25% occupation and you now have what we call tension pneumothorax, you have to put a needle in there first. Needle thoracostomy is for the patient I just described, the one who has all this stuff. No pulse, no blood pressure, he's cyanotic, he can see Kussmaul, pulse period. It means blood is not moving. Why? Because you have positive pressure in the thoracic cavity. Remember you learned last week. If you don't have negative pressure in this thorax, blood and air cannot move in there. Well, a pneumothorax puts positive pressure in there. That's it. Blood and air start moving. That's why the person temporarily dies till you do something. Okay? So when they have a tension pneumothorax, what do? Put a needle in their chest. It's called needle thoracostomy. Where do you put the needle? It's usually an anatomy question. They're going to ask you that. But they expect every doctor to know how to do these. That's what I'm going to explain it to you. Needle thoracostomy, put a needle in the second intercostal space, mid-clavicular line. How do I remember that? Because air rises straight to the top. Your lung, the apex is right there in the middle, mid-clavicular line. So there'll be a pocket of air sitting right at the top. So as you put the needle in there, you hear the air escapes. All of a sudden, pulse comes right back. That's because you're taking the pressure off the lung and the heart. Question, Cynthia. Question about pneumothorax is? No, you get Kussmaul sign with, so she's asking, do I get Kussmaul sign with a pneumothorax on the left side only? No, either one. But obviously it occurs faster with one on the left side than one on the right side. No, the other way, sorry. One on the right side, because you're pressing on IVC and superior vena cava. That means blood cannot enter the heart. Yep. Yeah, but either side can do it. So needle thoracoscopy, again, anatomically, second intercostal space, mid-clavicular line, you'll hear the air escape, pulse and blood pressure come back, and then you do the chest tube. What do I put in the chest tube? Fourth or fifth intercostal space, but now it's mid-axillary line. These questions are usually anatomical. They want to make sure you know how to do it, because every doctor is supposed to know how to save a patient's life with a pneumothorax. Fourth or fifth intercostal space, and then you angle the tube upward, because remember, the air is still up in the second intercostal space. How do we get all the way down to fourth or fifth? Because when they start out the first or second, you got an intern who's got to learn how to do the procedure. He's got a scalpel in his knife. That's dangerous. What happened? Axillary artery and axillary nerve right up there. They got sliced. People died. So we stopped doing that. Then we went to third or fourth, and you still angle upward to the first or second spot. That's what we've been doing for the last 20 years. Well, somebody did a retrospective, said, okay, we still killed too many people when you got an intern who still doesn't know what he's doing yet, and still killed a few people. So we said, okay, let's go down to fourth or fifth. That's where we are now. But just so you know, we worked our way down over time. Okay, it's based on physician error. All right, so fourth or fifth for pneumo, for hemo, blood settles. So you put it down one more, fifth or sixth, and then face it downward. Josh. What is the acceptable level of patient death? Yeah, what you do is, there's no acceptable level. What you do is compare it to another group of patients who are hospitalized, but who didn't have this, and see what their death rate were. Whatever that number is, if you got a number way lower than that, then that means their procedure is what's killing them. Yeah, so you always got to have a control group to compare it to. All right, so chest tube placement, fourth or fifth intercostal space, angle upward. I'm going to talk it through for you. Just visualize this with me. Don't try to write down every word, because you're not going to catch every word I say. We say, let's say, Mr. Johnson. I say, Mr. Johnson, I say, put your arms over this table. Why am I doing that? Because I want to maximally open up his lungs. And the best way to do it is have your arms out like this. That way it opens up the sides, okay? Now, I pick my spot, I clean it, I numb it with some lidocaine, I'm ready. I say, okay, Mr. Johnson, take some deep breaths. I let him take some deep breaths. Why? I want him to be hyperventilated to decrease his respiratory drive, because I'm about to have him hold his breath for about a good 60 seconds. And you can't have somebody who have a strong drive and you're trying to let them hold their breath for 6 seconds. It ain't gonna happen, okay? So you wait till they take maybe 6, 7, 8 breaths. You say, okay, hold it. This is on inspiration. If you say hold it, guess what? I'm gonna need this. The lung and chest wall are together. When you say hold it, they're like this, okay? That means you tell me inhale, hold it. They're right next to each other, because I want to know where the lung is my left hand, the chest wall is my right hand. I want to know that they're right together. Then I'm going to say, okay, exhale, but only for half a second. Exhale, hold it. See what I've done? Only the lung has moved. Chest wall is still standing still. That way now I know this lung is far away, because I'm about to come in here with a knife. You don't want the lung sitting right next there. You just slice his lung open. Now he's got a bigger pneumothorax. So for half a second, you say exhale, and then the lung moves away before the chest wall even moves. You hold it right there. Now you take your scalpel, cut that space. So let's say here's a space. I've just cut it. See that? I put in my chest tube like this and angle upward like that, because I want to get up there to that second space where the air is. And you just see air start escaping. The other side, you put it into a bottle of water. That's called a water seal. Why? Because air can get into water, but air cannot come through water back through that tube. So you created a one-way valve, which is nice. Because as soon as you put it into the bubble, that's just bubbles coming out. That's air escaping. Now you have a visual on whether the air is coming out or not. I like that one. The other one is wall suction. You put it into a tube in a wall and you hear this. See, that thing is sucking air out of their chest. Okay, but you don't really know if it's getting anything or not getting anything. I like water. That way, as soon as I walk in the room, I see bubbles. That means the air's still coming out. And I walk in there a few hours later, oh, no more bubbles. I said, okay, maybe it's all gone now. Any questions on how to put in a tube? Now, after you put in that tube, remember, I've got the tube in here like this, but I still got a hole right here. So what you do is take gauze, put a bunch of Vaseline on it. Air cannot get through Vaseline. Right here like that, see that? And then you sew that gauze to the skin and take the suture around the tube. So now both things are permanently right there on the chest. And then he can breathe all he wants on him. Is there an increase in waterborne infection because of the tube? I mean, that nah, because the bottle is so far away from his chest, we don't see it. Okay, now, how do I get this tube out of his chest? So let's say I walk in later on that evening and I see no bubbling. All right. And I say, hey, I wonder if all the air is gone. So when you have somebody on chest tube, we usually check on them right before lunch, right after lunch, and then at the end of the day. Because if you want to get the tube out, here's how we do it. You walk in there, you don't see any bubbling. First thing you do, put a clamp across the chest tube. I want to see if no more air will collect. I put the clamp and then wait 2 hours. Come back. If you unclamp it and you see bubbling, that means that pneumothorax is not finished sealing up yet. Everybody understand that so far? If I come back 2 hours later, unclamp it, nothing comes out, the hole is sealed. You can pull it out. And the way you pull it out is the same way we put it in. Take a deep breath, sir. Hold it. See? Now, this is a chest tube here, and it's sealed between my two hands. See that? And then I'm going to say, inhale, hold it. That way he's got to smash like this. And then pull it out like that. See that? Because he's done breathing in. So no more air can go in. And that's why you just pull it out and then, sew up the skin after he exhales. Any questions on that? All right. That's first scenario, if everything goes well. After you put in a chest tube, we always do a chest x-ray to make sure that tube is in the right spot. Okay. Now, what if things don't go right? Scenario number 2. I walk in that room hours later. It doesn't take long for air to escape, folks. Remember, air goes high pressure to low pressure immediately. So let's say I put it in at 7 a.m. I come back at 11 a.m. and I still see bubbling as if I just put the tube in. Anytime you see bubbling hours later, as if you just put the tube in, that person has a hole in his cartilage. And cartilage is avascular. It does not seal up on its own. They need surgery. So that's, let me see, what's the word? Oh, bronchial tear or bronchial rupture, like stab wounds, gunshot wounds. It went right through the cartilage. It's not going to heal up. That's why every breath he takes, air just comes out with every breath. And that's why it's still bubbling like you just put that tube in. He needs surgery. Any questions on that? All right. So that's pneumothorax. They expect everybody to know how to take care of somebody, save their life for this. As free radicals traumatize the airway, Bailey, we're going to phase 2. The airway starts to produce mucus to protect itself. By producing mucus, Bailey, airway will thicken. Goblet cells will undergo hyperplasia. What does that mean? They multiply in numbers. That's because now your lungs say, I need more mucus. Okay, well, here's more goblet cells then. That means the airway will lumen because it's full of mucus. And that way you have increased read index. Let's look at what that is. So here's the airway, like this. Here's the wall of your airway. Just put a dashed line. The space occupied by goblet cells divided by the total wall thickness equals read index. So as what fraction of the wall is occupied by goblet cells? It's usually somewhere between 0.2 and 0.3. But all of a sudden it goes up to 0.4, 0.5, 0.6, 0.7. That means almost the whole wall is being occupied by goblet cells. That's too many. That's how you know you got an airway problem now. So read index is either increased or normal. There's no decreased read index because you always have a baseline number of goblet cells. But what you're developing now is an airway disease that we call bronchopulmonary dysplasia. This is the first obstructive lung disease. However, Bailey, it turns out that every obstructive lung disease has the exact same profile. Oh, I love this, folks. Look at this. Obstructive lung disease, have trouble breathing out. Restricted, have trouble breathing in. All you gotta do is look at your patient and you can tell what kind of disease they have. All right, problem with ventilation, rather than restricted, which has diffusion and perfusion. I never said those two words. I never said ventilation when I was talking about restricted. Okay, that means if they mention, this is what I mean by all you need is one word and you already know the profile. You should get the answer right. You don't have to know what disease they're talking about, but you can still get it right. Okay, look at the blood gas. If you're not ventilating, the PO2 can be normal or low, depends on when you catch them. When they have severe bronchospasm, that's it, PO2 is low. But most of the time, spasm will then break, oh, PO2 is back to normal. That's why they say normal or low. But definitely your clue is PCO2 is high. If you're not ventilating, the CO2 is not leaving. And CO2 is an acid, so pH is low. Look at that, totally opposite blood gas than what I gave you for restrictive. Again, it's only if you understand it, folks, then you actually pay attention when they give you the blood gas. One word gives you the answer. The blood gas gives you the answer. But that's only if you understand it, it tells you behind it. Because as you know, you've seen these questions many times. But because you wanted to know exactly what disease it was, then you missed the question. Now realize you don't need to know what disease it is. You just need to know restrictive or obstructive to answer the majority of pulmonary questions. Just letting you know in the secret. That's why it gives you the clue almost every time. Every time I look at it, I see it. It's there. Obviously, before Dr. Shah, I didn't see a thing, man. I just saw somebody wheezing. I wonder why they're wheezing. And I was off just like every other student trying to figure out what disease they're talking about. All right, so anyway, too much airway mucus, like I just said. Airway thickening, like I just said. Gallus hyperplasia, like I just said. Increased read index, like I just said. And the most common cause of death now is called bronchiectasis, which means digestion of your alveoli, Anders. You can't breathe without alveoli. You understand, Anders? You understand, Saba? You understand, Naif? You understand, Gloria? How about you now? You understand? You understand, Saba? All right. You understand, Maria? I think so. Well, you didn't say yeah, so that means I got to sweeten up the deal then. All right, so let me put something else on top of this. Here it is. Folks, it turns out, Maria, that bacteria love your airway. Why? Because they feed off of food. You and I aspirate food into our airway all the time. Everybody understand that? So bacteria, if they like your airways, that can be restricted or obstructive. Obstructive, trouble breathing in or out. Trouble breathing, no, stop that. Trouble breathing out. Trouble ventilation or diffusion? Ventilation is going to be increased or decreased? Decreased. You're not blowing it off. That's decreased ventilation. And therefore the PCO2 will be high. pH will be low. Read index will be high. Tell me one thing I'll see when I look in the airway for a bacteria. Thick airway, increased mucus, increased read index, all the same thing you just heard. What's the most common cause of death for bacterial pneumonia? Bronchiectasis. What about if it's Staph aureus pneumonia? Staph aureus pneumonia, most common cause of death is what? Bronchiectasis. Klebsiella pneumonia. Bronchial E. coli pneumonia. Bronchial aspiration pneumonia. Bronchial actinomyces pneumonia. You can open up any book you want. Check if I'm wrong. It'll blow you away. It's always been the same thing. You guys just didn't pick it up because it was never taught to you. It was never taught to you. This is what I mean, folks. Pulmonary, I rack up a ton of points. I don't even know what the hell disease they're even talking about. I just see one word, obstructive. I answer the question. I don't have to care what bacteria they're talking about. It's always the same answer. I mean, one rare one I'll miss. Let it go. See, you start worrying about this one rare pneumonia that does something different. I'm telling you, there's always an exception. That's what I'm saying. Stop worrying about the exceptions. When they're less than 10%, I'm not worried. I'll take a 90 plus on anybody's exam. Okay, that way you've done well on the exam. Versus you keep worrying about these exceptions and then you can't even hit 62%. That's because you're worried too much about the exception. That's what costs you the exam. Anna. If you got bacterial pneumonia, the most common cause of death is still going to be the key. The key is pneumonia. That means in the lungs. Sepsis is going to be different. Yeah, sepsis is different. So every bacterial pneumonia, bronchiectasis. End of story. That answer's never been wrong. Okay. For everything else, non-bacterial. Justin. Everything else non-bacterial. They like to live in interstitium. Why? That's where the oxygen is. They need that oxygen for replication. So for anything non-bacterial, you're going to put it interstitium or airway. Interstitium. Is that restrictive or obstructive then? No. Again, make sure you're paying attention to this profile. Okay? Airway is obstructive. She just did obstructive. Anybody else in interstitium is restrictive. Everybody understand? All you need is one word clue. The minute I say interstitium, I just made it restrictive. That means you should know the rest of the profile after that. Everybody else understand that? All they need to give you is one word, folks, but you got to study these words because it's worth 1,000 points. You got to know it cold. Because I don't know which word they're going to give you, but I see it when I look at a question, and you can see it too. That's only if you know it well. All right. So what I'm saying here, Justin, is that anything non-bacterial, I'm going to say restrictive. Everybody follow me? That means that I don't care if it's virus, fungus, protozoa, cardiovascular disease, cancer, I could care less. I'm picking the same answer all the time. See? So that means if you got pneumocystis jirovecii infection in an AIDS patient, CD4 count of 127. Is that going to be interstitial or airway? Gustavo? Interstitial, restrictive or obstructive? Restrictive, trouble breathing in or out? Trouble breathing in. So the PO2 will be what? Low respiratory rate? High PCO2? Low pH? High. So if the PO2 is low, pulmonary vessels are going to constrict or dilate. No, oxygen dilates pulmonary vessels. Hypoxia constricts it. So pulmonary pressure will do what in pneumocystis? Increase pulmonary resistance will do what? Increase pulmonary blood flow will do what? Decrease pulmonary capillary wedge pressure will do what? Decrease. Is this going to create a resistance or volume problem? Resistance is going to affect S1 or S2? No, there's no S1 in pulmonary. All right, now everybody, hope you guys are studying these profiles. Okay, don't ever mix them up. You're not going to get any points. You may get 1 point out of 100. I'm not interested in 1%. I want to pick up over 90%, just thinking the same thing all the time. But notice that way for pneumocystis, what I do, I say all the same stuff. That means that most common cause of death, cor pulmonale. I'm not changing my mind for anybody. It's the same answer. That way I don't have to look up a virus, adenovirus, RSV. Otherwise, when you don't know that, you think you got to go read 10 more chapters to get ready for an exam. And I'm saying, no, just know your profiles. That covers a ton of ground, and you never have to look it up. Why? Because you're right over 90% of the time. Nothing's right 100% of the time. So please don't expect that. But if I can get over 90% without worrying about it, I'll take it. Okay? All right, so that's obstructive lung disease profile. I always like to start with RDS. Why? Because RDS starts off restrictive and then morphs into an obstructive lung disease. That way I cover both profiles with one disease. Now you know the profile, or hopefully you will study these profiles and know it well. Steve, question.
So both resistant and obstructive have increased respiratory rate.
Both restricted and obstructive have increased respiratory rate, right? Because they're both tachypneic and dyspneic. They both have weakness, shortness of breath. Nothing changes.
But then how come increased respiratory rate of obstructive gives you hypercapnia?
Why is it only the obstructive gives you hypercapnia? It means increased PCO2. Karina will explain to you.
It's not gonna be able to get over.
Wait a minute, I think you said it backwards. Yeah, obstructive has poor ventilation. So even though they're breathing fast, CO2 is not getting out. That's why their CO2 is up. Because they have an airway problem. There's mucus in their way, can't get the carbon dioxide out. Restrictive don't have an airway problem. So with every breath, CO2 is leaving. That's why they have respiratory alkalosis. All right. Obstructive. Any questions? You understand it, Karen? Yeah.
Yeah, so you said that both have increased respiratory rate.
They both have increased respiratory rate because everything in the lung makes you breathe faster. Right? Doesn't matter if you have an airway problem, interstitial problem, you're going to breathe faster. Because if your PCO2 is up, your brain says breathe faster, so you can blow up the CO2, even though you can't. If your PO2 is low, your brain says, hey, could you breathe faster? We need more oxygen. Either way, you're getting the same signals. You understand, Ryan?
Yes.
You understand, Acid? All right, we move on. Every lung disease presents with the same signs and symptoms, folks. There it is. Every lung disease. You hear what I just said? That's what I'm saying. You don't have to look this stuff up anymore. They're all tachypnea dyspnea. They're all weak and short of breath. That's why is when you get the blood gas, then you know which one it is. Why do you think as soon as they come to emergency, we get a blood gas? See, that's management rather than just memorizing. That's what we do. You now know why we do it. Because only the blood gas can start to separate it from airway or interstitial for you. Okay? Can it really be this easy? Yeah. All right, so amylin food production. You've heard this 3 times now, I think. One more time. Since the lung is involved, I thought, let's just do it again. Please listen, because you got to be able to tell this story and come up with the information again. The mom supplies 90% of the amniotic fluid. However, the baby swallows away 10%. His brain has to tell him to do so. His autonomics got to work. His esophagus got to be open, and the muscles got to work as well. And the upper GI has to be open. So that means if the baby cannot swallow, are you going to have too much or too little, Gloria? Too much. And that word is polyhydramnios. Polyhydramnios is when you got more than 24. Remember, we use 8 to 24 now. More than 2,400 cc's per quadrant. If you have polyhydramnios, you have 2 big complications. Adnan, give me one. Sandeep, give me one. Potters is oligo. I'm on a poly. Nave, give me one. Uterine rupture is the worst, but that's a distant number 2. What was number 1, Jess? Yeah, preterm labor, because you're distending the uterus with fluid. It's not baby, but the uterine wall doesn't know that. Once you get to a certain stretch, boom, labor begins. Preterm labor happens 90% of the time. Uterine rupture is very rare, but it's so devastating when it happens. And I explained it to you. Sudden gush of blood everywhere. Her vitals crash. And when you examine her uterus, you can feel the head popped out. They usually hint at it by telling you the station just changed. The baby was -2, all of a sudden, boom, +1. That means he popped back up. Okay? Anna. No, that's not the turtle. Turtle sign has to do with the delivery process. We'll talk about that tomorrow. All right, so that's 80%. To subtract, I just gave you the 5 things that you have to do to subtract. 20, the baby takes his 10%, adds another 10%, and then pees into the sac. In order to add, he has to be able to urinate. So if you cannot urinate, you're not able to add. Is that going to give you too much or too little, Miguel? If the baby cannot pee, you cannot add. Is it going to give you too much or too little? What? Too little. What's the word for that? Oligohydramnios. So amniotic fluid less than 800 cc's per quadrant. All right, role of amniotic fluid. Remember, shock absorption was number 1. Number 2 was to absorb atmospheric pressure away from the baby. For what reason? To allow the alveoli to inflate. You cannot inflate a balloon into positive pressure. If there's negative pressure, then it'll inflate. So polyhydramnios, your differential. Again, you've seen this before. Just reminding you how to put it together, and you'll see there's only one answer on the list. That's what I see. But I always go through the 5 areas and look on the list, only one. That's how you know test writers congratulating the students organized. The students not organized just memorize a long list of stuff with no rhyme or reason or understanding of how they came up with that list. That means you can't duplicate it day to day. All right, so neurological defect, they can go down to be a vitamin. I say, what vitamin are they looking for? No, not E, not B. B9, folate, brain. Then make sure you connect. All right, autonomic dysfunction, remember Raleigh Day. Neuromuscular disease, Wording Hoffman. All right, upper GI atresia, esophageal atresia, and duodenal atresia. What's the clue for esophageal atresia? Gloria. Esophageal atresia, Anders. Drooling since he was born. He can't swallow his own spit. All right. And remember when you put in a nasogastric tube, curls and comes right back up at you. That means there's a tube there. You do your water thin contrast, gastrographin, and you see a pocket. How come that pocket is there, Karis? What failed to happen? Apoptosis didn't happen. What gene controls that? P53. What protein helps out? Big D. And what's his label? Phosphatidylserine and the Hitman. Caspase. Everybody should know this should be an old song, okay? Again, repetitions to help you. Don't be writing stuff down again. All right, duodenal atresia. Give me a clue, Steve. Yeah, double bubble sign on X-ray. Bilious vomiting. Remember, bile gets dumped to the second part duodenum. So bilious vomiting 30 to 40 minutes after the first feeding, because food can't even get past the membrane. And again, apoptosis didn't happen. And then hypothyroidism is because without thyroid, nothing works out right. All right, oligodramnios, something's wrong with the kidney system. Number one, the renal agenesis, you don't have it. And that's metanephros, right? Metanephros. Then develop, or the ureteric bud failed to make contact with it. Still won't get any kidneys. Or there's an obstruction in the bladder, posterior urethral valves. Or they'll call it a persistence of urogenital membrane. That's what actually causes the valve to be back there. But it's in the back of the urethra, so that's why they posterior urethral. So that means when urine tries to go out, it hits this membrane and won't go out. For that reason, the most common cause of abdominal mass in a newborn is what, Ashley? Not neuroblastoma, Halima. All right, Josh. Most common cause of abdominal mass in a newborn is what? Now, let me ask Leslie.
Enlarged bladder.
An enlarged bladder. That's how common posterior urethral valve is. Enlarged bladder. It's after the newborn period, Ashley, then it's neuroblastoma. So watch out for this one, okay? So oligodramnios, what's the main complication for that, Angie? Potter sequence. So without enough amniotic fluid, your lungs will not inflate. If they will not inflate, the baby comes out and he dies shortly thereafter. So what do we do? If I see oligodramnios now, anytime after 24 weeks, what are you supposed to do on them? Oligodramnios after 24 weeks, what are you supposed to do? No, not Salumadrol. Karina will help you on this one. Immediate C-section. Remember I told you that baby's being smashed by a rock. There's no need to hold off till tomorrow. We do it immediately. And remember, after 24, you got a 50-50 chance based on today's technology of saving that baby's life. Whereas before, 100% died. 100%. There was no way to save any of them. Okay, just so you know, why are we saying immediate? Because at least you have a chance to save half of them. All right, so that's oligo. Potter syndrome or Potter sequence. So when oligodramnios leads to pressure effect on the fetus, everything is flattened. His face, his chest, his lungs, everything. Okay? Prune belly syndrome. You see, nice picture there. The baby's belly looks like a prune. Is lack of smooth muscle in the abdominal wall. Has mesenchyme, mesoderm, connective tissue. So the mesoderm did not crawl into the abdominal wall, so there's no muscle there, so he can bear down and pee. So if you can bear down and pee, guess what? You got the exact same problem. You're gonna end up with a Potters because you cannot pee. That means you cannot unload. So that baby's gonna have a big bladder when he's born. Same problem. Well, this happens if you have a neurogenic problem. That means the nerve to your bladder doesn't work. What's the most common cause of peripheral neuropathy, period, in America? Leslie.
Diabetes.
Diabetes. So diabetes is number one cause of neurogenic bladder. So the nerve doesn't work, they're pushing and pushing, hardly anything comes out. So what do we do for prune belly or the person with neurogenic bladder? We teach them how to put a catheter in there. So for mom, we teach her how to cath this baby every 4 hours. Most people urinate every 4 hours. And if you're sticking a foreign body into somebody's urethra every day, Halima, what's the most common cause of death now? What's that? All right, Jess? Infection, UTIs. What's the top bacteria, Jess? E. coli followed by? Proteus followed by? Klebsiella, they say nitrite negative. Enterococcus postcoital. Saprophyticus, they want virus. Adenovirus. All right. For neurogenic bladder, for diabetic, remember I told you if it's early, you can use a medication to help them out. What's the medication that we talked about for early neurogenic bladder? Maria, do you remember the name of the drug? Early neurogenic bladder is a drug you use to treat them. Let me ask Abdullah Khan. Abdullah, do you know them? Was that?
I'm not
No?
sure. I think it was like.
All right, Jolita, do you know the name of the drug?
Can't remember.
All right, Akuna.
Is it Bethalacan?
Close enough, girl.
Okay.
I'm happy to hear something that sounds like what I want. So bethanacol and carbachol were the two I gave you. Early neurogenic bladder. So to avoid cath, it'll give them treatment for like 1 or 2 years. I mean, hey, if you push off UTIs for 2 years, who wouldn't want that? Okay, but then after the nerve dies, nothing you can do about it. You got a cath. All right, very good. All right, any questions on Pulm belly or Potter's? Next one then. How long they live? Oh no, they live probably their teens maybe. Yeah. Well, some of them will die early though, because you know when mom's got to put the catheter in, if you got a mother gets frustrated, she does it the wrong way and puts germs in there. Yeah, not much you can do, but they can live into their teens. It's important to have negative pressure in the thoracic cavity. Hopefully, I've impressed you with that, because if you don't have negative vacuum in your chest, air and blood can't move in there. You understand that, Solange? You understand that, Meha? You understand that, Hannah? You got to have a vacuum in your chest. Air and blood cannot move into positive pressure. So diaphragmatic hernia is another problem to worry about. The diaphragm forms in everybody from ventral to dorsal. That means from the front, spins around to the back, dorsal. Okay? It turns out the left side is weaker than the right side. So for that reason, 90% of diaphragmatic hernias are on the left side. How do you recognize it? Well, if you got a really good ultrasonographer in utero, we can see it. But most of the time, we find out after they're born. After they're born, all of a sudden you hear bowel sounds in their chest. That's not supposed to be there. Bach to leg defect, B for back. Because remember, you spin from the front to the back. The hole is going to be in the back if you pull out a baby prematurely. So it makes sense. And I already said 90% are going to be on the left because the left is weaker. Morgagni, M for midline, means after you already formed it, it then ripped. And that would be rare. Bowel sounds in the chest is how we detect most of them. You must repair surgically right after birth. Why? You're hoping, Josh, that this happened late in development so that only part of the lung got collapsed by the intestines. Because if it happened early and the lung is completely collapsed, that baby's going to die after you deliver him. But you're hoping to save a few by getting the intestines off that lung and letting it reinflate. We use a little positive pressure to inflate it. Because that's the only chance that baby has. If not, they die. Josh. If I hear bowel sounds in the chest of an elderly individual, still a diaphragmatic hernia. It happens is late in trauma. Like if they were in a car accident, they say, I'm okay. About 2 days later, all of a sudden now they get severe chest pain and they can barely breathe. There's usually delayed rupture of the diaphragm after severe trauma. Yeah. Car accidents, I've seen several of those. All right, so diaphragmatic hernia is nice picture. Remember, we saw that in one of the morning questions. You see all of a sudden that right side there is all popped up to the middle now. Anatomy of the lungs. All right, this is just for you to look at, just so you get a visual. All the way to alveoli, where oxygen exchange will actually occur. All right, let's talk about them. There's exothoracic airway. Exothoracic means outside of the thorax. That means not protected by the rib cage. Exothoracic airway, from the lips to your glottis, is exothoracic. Okay, it narrows when you inhale. That's why you hear noise, because it's collapsing when you inhale. It expands when you exhale. That's why you don't hear any noises. So you got to know the movement with each breathing cycle. Exothoracic narrows when you inhale, expands when you exhale. This is why when somebody's breathing too fast, you know, a child who's really scared about something to happen, and then breathing fast, you can hear that. That's called stridor. That means you're collapsing your own exothoracic airway. You're making it even harder for yourself to breathe. And so that's why we say, okay, slow, deep breaths, slow, deep breaths. You're trying to slow them down because they don't realize the faster and harder you breathe, actually the less you're ventilating yourself. Okay? So that's exothoracic airway. And an intrathoracic airway from the glottis to the alveoli. So the Glottis is a dividing line. From the glottis down to alveolus, expands when you inhale, narrows when you exhale. So the opposite. For that reason, it means when a person makes a noise when they inhale, on them, where's it likely coming from? Intro or extrathoracic airway? Which one? Yeah, extrathoracic. If you make a noise when you inhale, extrathoracic airway. Make a noise when you exhale, intrathoracic airway. A noise when you inhale, we call it stridor. A noise when you exhale, we call it wheezing. And they both mean the same thing, narrowing of the airway. Just where is that narrowing? Your intrathoracic airway has a vacuum around it. And that's why when you inhale, it opens up wide. Even if there's a narrowing, I wouldn't hear it. So wheezing on exhalation is expected. Does everybody understand that? Okay. But there was a big article back in the 80s. The title was, All That Wheezes Is Not Asthma. Why? Because every pediatrician, every kid that wheezes, they were calling it asthma. There's a million reasons for wheezing. And so they were just going through the physiology. Wheezing just means intrathoracic airway is narrow, not that you have asthma. Okay? Like foreign body. Children inhale foreign bodies all the time. Doctors were missing it because they were saying, oh, asthma. So the foreign body just stayed there for weeks. Yes. Stridor is extrathoracic airway noise. Yeah, slow, deep breaths. And then the airway will. No, wheezing, you have to treat them because that's intrathoracic airway. You got to give them a beta agonist or figure out if there's a foreign body down there. All right, that's intra and extrathoracic airway. Now, another way to divide this is dead space and alveolar space. Dead space is from your lip to the terminal bronchioles. Dead space. Why do we call it dead? Because no oxygen exchange can occur. From your lip to the terminal bronchioles, dead space. No oxygen exchange can occur in those areas. Zero. And then the rest of it is called alveolar space. Now, that's why I gave you the picture. I mean, if you can study it for yourself, but the areas that can exchange oxygen, one is called a respiratory bronchial. That means the bronchial that goes into the alveolus. Respiratory bronchial. Then the piece that goes into the alveolus itself is called the alveolar duct. Just renaming that little piece. And then alveolus itself. That's called alveolar space. One more time. Alveolar space. That means exchange of oxygen can only occur in these three areas. Respiratory bronchial. Alveolar duct. And the alveolus itself. That's the only three places that can exchange oxygen. One cell layer of thickness. That's it. Remember, oxygen is diffusion dependent. You put anything in his way, he can't get across. So those three areas have just one thin layer of cells. That's it. There's no cartilage, okay, in the way. That's how to know there's no cartilage down there, because that cartilage would be in the way. You'd have a diffusion problem. So dead space ventilation plus alveolar ventilation equals total ventilation. Does that make sense to you, Cynthia? Cynthia says, okay. You got to go through the dead space to get to alveolar space. Everybody understand that? So that's why they say dead space ventilation plus alveolar ventilation equals total ventilation. But the one that affects your oxygenation is alveolar ventilation. Dead space does not. Everybody understand that? You understand that, Cynthia? So the reason why I wanted you to understand that is because there's a difference between breathing and ventilating. The ventilation we're interested in is alveolar ventilation. You can breathe through your dead space and you're still not ventilating. And that's a huge difference. I remember one of my senior residents, his name was Gino. He was trained by Dr. Shah too. The guy was sharp. I remember we were on call together in Peds and he said, Francis, don't ever call the attending for asthma, a child with asthma or an adult with COPD until you get a blood gas back. So why is that? He said, because the first thing the attending's going to ask you is the patient ventilating well or not? And if you don't know the difference, it's so easy to say, yeah, he's breathing fine. You're fired tomorrow because you don't know the difference. You can be breathing fine and die right in front of me. That means I don't know the difference. Because the person can be ventilating, but it's all dead space. But they're not ventilating. How do I know that? The blood gas. That's how you know. That's why I said don't call until you get the blood gas. Because if you say, he says, how's the patient ventilating? I said, well, his blood gas was nearly 65 when he came in. Now it's 32. Everybody understand that? That means he's blowing off CO2. That means the alveolar space is working. Okay. What if I take a shallow breath, Mitchell? Are you sacrificing dead space ventilation or sacrificing alveolar ventilation? Alveolar. Because if you need a column this big, take a shallow breath. Do you see where it's going? You're pulling it out of the alveolar space. See, you're still breathing here, but you're not ventilating here. So nobody get the two mixed up. Just like in obstructive lung disease. They're tachypnic. But the question you asked me, see that? But they're not ventilating. That's why the PCO2 is high, even though they're breathing real fast. Question, sir? Yeah, blood gas always means arterial blood gas. Yeah, always. Yep. All right, so now trachea. The trachea is in the midline. Let's go through the whole airway now. Your trachea has 16 to 20 C-shaped cartilage rings with the opening to the C facing posteriorly. All right, let me show you what that means. Here's the letter C. Let's zoom in a little bit. Okay, here's the letter C, letter C. What you're going to do is face it backwards like this. So that means it's facing backwards. That's because right behind it is your esophagus. That way, when you swallow, you collapse your own trachea. See that? That's what prevents aspiration. Otherwise, we'd all aspirate everything that we eat. But even with this working perfectly, we still aspirate small amounts. But in case you're asked why the opening to the C always faces posteriorly, because the esophagus back there, when you swallow a bolus, will collapse your trachea for you to keep you from aspirating. Any questions on that? All right. You have 3 anatomical narrowings in your esophagus, sorry, your trachea. It's very important to know, Amy. One is the glottis. The glottis is the most narrow. Then the midway, and it's caused by aortic arch going across the anterior surface. So it might make that an anatomy question. And then the carina is where one big trachea bifurcates into 2 mainstem bronchi. Why do you want to know about these 3 places? That's where foreign bodies get stuck. Where's the biggest foreign body going to get stuck, Karis? No, not the carina. Ashley? The glottis is the most narrow space. It's going to have to cross there first. So most narrow is where most things get stuck. Everybody understand? I remember we had that one morning question, the kid who swallowed aspirated a coin. Where was it? Right up here? Right to the carina. All right. So when you got a foreign body, you do an x-ray, you got to know, look right up there in the midline, go, look at those 3 places, you'll see your foreign body. Okay. So the glottis is where most things get stuck. So that means if your glottis is closed off, Michael, if your glottis is closed off, that means air cannot move into your airway and also can't move outside your airway. You understand that, Halima? So the quickest way to assess whether somebody's glottis is open or whether somebody's trachea is open, that's what they'll ask you. What is the best way to assess patency of your trachea? You know, when somebody's down on the ground, I want to know, is his airway working? Okay, because if his airway working, then great. I don't have to do anything. But if his airway is not open, I got to do something. Everybody follow me? The best way to assess it is to have him make a noise. That's why we say, sir, are you okay? Are you okay? All they do, even a grunt tells me his airway is open. You can't make a noise if your trachea is closed off. Okay? So the quickest way to assess patency of the trachea is usually the question, is to have the person make a noise. Sir, ma'am, are you okay? If they don't say anything, we do one more thing. You take the knuckle of your middle finger, rub the sternum. That hurts like crazy. There it is. Trachea is open. That's all I want to know. It means I don't have to worry about your airway. Your airway is open. Because as long as the trachea is open, you can use one of the lungs. The other lung can be collapsed for all I care. You can breathe through the other one. That means you're going to be fine till the paramedics get here. Yes, sir. Yeah, that's what the sternal rub is for. It's trying to get them to make any kind of noise. Any kind of noise says your trachea is open. Well, yeah, I mean, if they're making a noise, they're not coming with those, because it means the signal went up to the cortex and they responded. Yeah, that means they're not coming with those. All right, so any questions on checking patency of the trachea? All right. Aspiration. That's when things don't go right, we can aspirate easily. Well, we all aspirate small amounts as it is, but if things don't go right, then you're gonna aspirate even more. So the question they like to give you is somebody, a stroke patient, well, you gotta know the brain's not working. Then you can't protect your airway very well. All right. If the patient is unable to speak, then the object is lodged in the trachea. Large objects tend to lodge at the glottis 90% of the time, so we always check that first. You perform the Heimlich maneuver. So Heimlich maneuver is for objects, large objects that's lodged in your trachea. Anybody ever seen Dr. Heimlich before? Dr. Heimlich, man, this is a real geeky looking guy, man. But he is, I mean, genius what he came up with. I mean, I have incredible respect for this man. So here's how he came up with it. All right, let me see, zoom out a little bit here. All right, here was his whole premise. He said, when you breathe in, okay, your diaphragm sits like this. When you breathe in, your diaphragm comes down and then comes around to the back like that. Everybody watch that? When you breathe out, it comes back to the middle and then cups up like that. That means even after you breathe out, folks, there's 2 pockets of air sitting up here at the top. See that? My hand is holding 2 pockets of air at the top of your lung, full of air. What if I could push that air through your trachea for you? That means if there's something up here in the glottis, there's a propulsive force coming around it, boom, push it right out. Amazing, simple, but incredible thinking to me. That all you gotta do is just push, and whatever it is flies right out. Heimlich maneuver, everybody's supposed to know how to do it. Take the thumb of your offhand. I'm right-handed, so I take my left hand. Put that thumb right at the xiphoid process. That means you're under the 2 pockets. Then you take your other hand and grab the other 4 fingers, wrap around the person's chest like that, and push straight up. When you push straight up like that, all the air goes right through the trachea, and a piece of meat comes flying out. Any questions? And you can find a xiphoid process on anybody. Now, that's easy landmark to find, okay? But let's say you call me a couple of years from now, Dr. Francis, I don't know about this Heimlich you taught us. This guy is 450 pounds. I can't get my hands around him. All right, then don't get your hands around him. What you do is ask for help. You ask somebody to help you, you lift the guy up. You take a chair, usually one with a straight back. And when you go to restaurants, it's usually straight back, right? Yeah, you just have him, you lift him and just put his chest right, xiphoid, right where the back of the chair. And all you guys gotta do is push on his back and you get the exact same thing. And piece of meat goes flying out. He said, doggone it, Dr. Francis, I don't know, I got a 2-year-old. If I put my hands around him, I'm gonna kill him. I said, well, don't put your hands around him then. All right. No, we don't do that. 2 years and above, 2 years and below, we don't do Heimlich. What you do is called a back thrust. You lay that baby head down on your thigh. His chest will wrap around your thigh exactly the way we want. And all you gotta do is take the heel of your hand and hit the middle of his chest, and you get the exact same propulsive force. Head down means piece of meat will come flying out. That's how you save a life one day.
When do you have to stabilize?
The stabilized in the hand is for newborns. Yeah, for newborns, because they're so tiny, you can't even put them on your thigh. You just hold them on your hand like this, and you do the same thing on the back with 2 fingers. All right. Any questions on that? If you're alone and choking, use the back of a chair. Yeah, before you pass out, because you're going to pass out. All right. So, yeah, she brings up a good point. If you're by yourself, nobody around, you're going to die if you don't do something for yourself, right? You get to a chair as quickly as you can and use the back of that chair. Just go down like that. And then hope that piece of meat comes flying out before you pass out, because that only a certain amount of time you will pass out. Okay. All right. So now let me teach you about the Good Samaritan Act. Good Samaritan law was passed many years ago to take all liability away from physicians for helping other people. Because they knew that doctors would be afraid to help people because they thought you'd get sued if you did something wrong. So they took all liability away. The law says if you perform a procedure that you've been trained to perform in the process of helping saving somebody's life, even if the outcome is adverse, you cannot be held liable. Why? The patient would have died if you did nothing. Everybody follow me? And that was very wise of them, because otherwise the person would have died. So let the doctor take a chance and try to do something to save the person's life. But if I got to worry about getting sued, then I'm going to be, I don't know if I want to do that. And then boom, take off. And the person will just die right there. Yes. No, if you've been trained, you can do it. You don't need a ambulance driver's permission. No, if you say I've been trained, they trust your word. I mean, if they want to, they can call your residency and say, do your residents get trained in this procedure? But that's rare. I've never seen them or heard of them calling any residency to verify. Yeah, that's why I like doing the chest tube. I had to teach you. Pericardiocentesis, I taught you because I expect every doctor to know how to do this to save a life in an emergency. Okay. So if you perform a procedure you've been trained to do, even if the outcome is adverse, you cannot be held liable. But part two says, you only do procedures that you've been trained to do. If you've never been trained to do it, don't try it. Everybody understand? You can't say, because I stayed at Holiday Inn Express last night and watched some video on craniotomies. You know what? I'm going to do a craniotomy today. No, you were never trained to do craniotomies. You ain't about to do it today either. Everybody understand? Okay. Number three, if you're not in your right mind, don't attempt it. Meaning if you're drunk, if you're at a bar and somebody starts dying because of some reason and you've already had a few drinks, don't do it. Because now they can turn around and sue you and say it's because you were drunk. That's why they died. The family will sue you, not him. Okay, but don't do it. All right. Next, you cannot accept any form of remuneration, which is the word they use, but that just means payment. You cannot accept any payment for what you just done. Everybody understand that? From the person or anybody related to him. That's what the law says. But I always tell students, just don't take any form of payment at all. You don't know who's related to who. All right. Because there's been times a doctor helps somebody at a restaurant. What the managers always do, can I pay for your meal for you? That's payment. And then you find out he's related to the guy that just went to the hospital. You're in trouble. You're in trouble because you accepted payment. Next, if you accept any form of payment, folks, you just sign a contract to be that patient's doctor. You have to follow the ambulance to the hospital where they're taking them to fulfill your duty as his doctor. That's what the law says. Okay. Which means if the doctor accepts payment by getting free dinner, and then he didn't follow the ambulance to the hospital, see, that's one of these surprise lawsuits. You know, lawyers, I remember they used to call lawyers ambulance chasers because they would see how doctors didn't know this law very well. And so it was easy lawsuit. You're going to lose. Because if they find out you accepted payment and then you didn't go, that's called abandonment. You abandon your own patient. You can be sued now. Okay? Everybody understand that? Yes, sir. What if their mama invites you to dinner? Oh, the mama was out with them? No. You're always allowed to accept food and cards, cookies, cakes. Yeah, that's not considered payment. Yeah, it's got to be something of monetary value. Airlines, yes. Frequent flyer miles, yes. You're not supposed to accept. You're not supposed. You don't accept upgrade either. That's payment. That's payment. The key is, I always tell students just say no because I don't want to have to try to figure out who's related to who, and then and get blindsided by a lawsuit. And then you find out they were related somehow, and now there's no way for you to erase it because you're in trouble. Okay. Last part of the law says this: if you do not try to help somebody in a time of trouble like that, then you can be sued for that. Yes, that's part of Hippocratic oath. You put your arms up and you say, hey, I am willing to put other people's lives before mine. The lawyers remind you, you signed a contract that says you're going to try to help other people in times of trouble, and yet you drove right by. Did you know if you pass a crash and you're a doctor and the crash just happened, you're supposed to stop and see if you can help somebody? This happened to me one time. I was heading to Chicago. I got on 57. I had that accelerator mash the ground while I was blowing dust flying around. I mean, yeah, should be in an hour and a half. No problem. I got this. And just when I got barely to Market Street, all of a sudden I saw a little Toyota behind me. They hit something that was trying to run across the street. And all of a sudden they, boom, 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 they roll over 3 times. I'm like, oh, damn. Okay. You know, so I hit my brakes and back it up. Luckily, there were 3 ladies in there. Yeah, 2 in the front, 1 in the back. And I looked at them and said, ladies, is everybody okay? Oh, good. I ain't got to do nothing. I heard 3 That's all I want to hear. That means everybody's airway is just fine. And remember, you don't want to move anybody. So it's best just leave them right there in the car. I could hear the siren. Paramedics were already on their way. You know, 2 hospitals 5 minutes away. So they were already on their way. As a doctor, I'm supposed to stay there till paramedics get there. Once I get on the phone with the ER physician, that ER physician has now accepted responsibility. I can now drive off. That's the law. Because I remember when I was a resident, I remember one attendant gave me terrible advice. He said, if you're on vacation with your wife, he said, make sure you don't tell the hotel you're a doctor, because if somebody starts choking, all that, they'll come get you to come save a life. I'm like, man, obviously he didn't read the last part of the law. If you don't try to help somebody, they can go back and sue you for it because you had a chance to save a life and you just ducked out of the hotel. You're in trouble now. Okay. So that's what I'm saying, folks. Better know the rules yourself so you don't have some attending influence you to do the wrong thing because he's been doing the wrong thing. You don't want to be the one that gets caught for it. Okay. So anyway, that's how you do it. Yes. 2 questions. Does this apply to medical students? Yes, only if you've been trained to do it. Now, I learned this when I was a medical student about this Good Samaritan law. When I did that, when I learned it, I said, oh man, I remember, I think it was Gino or another person saying, run to every code. You know why he said run to every code? Because when you get there, as the first one to get the code, you get to do all the procedures. That means even if you screw up, you can have you sued. See that? Most residents don't get that information. Gino, I think, is the one that passed on to me, said, man, go to every code. That way you can do every procedure. Even if you screw up, they can't sue you for it. Because the guy would have died if you didn't try something. Because it's an unwritten rule. Whoever gets there first, you get to intubate them, put in a chest tube, put in an art line, do whatever needs to be done. You get first dibs on it. So man, I was running to every code I could, boy, so I cut somebody. I'm telling you, man. In an emergency situation, I call it the hero moment. Oh, but don't tell me to cut somebody in a normal, sane moment. I can't do it. I told you, no, nurse, please. Turn on the fan. Turn up the fan, man. It's hot in here. I can't do it. But hero moment, spring, get out of my way. Hey, I'll tend to the patient. Call 911. And then you go right there and just start doing whatever you got to do. Because that way I know I cannot be sued even if I mess everything up. Patient would have died anyway. Okay? But that's how you get all the practice you need. I mean, there were times they wake me up out of REM, man. I'm like, ooh, I got to get there fast. And because I sleep like this with my pillow, my arm underneath the pillow. This arm was asleep. I'm like, come on, man, you got to wake up. We got to go. I mean, this arm was behind me, flapping in the wind. I'm trying, come on, man, you better wake up. Because I can't even do CPR because this arm is asleep. I'm like, come on, wake up. We got to get there fast. I'm trying to get there so I can be the first one to get all the procedures done. I loved it. And then I did 2 weeks in trauma surgery. That's another one. You get to do every procedure right in the ER. I loved it. Those are the moments where I love it every moment of it. And then when I went up to NICU, you get to do every procedure on the babies too. Now, if you can do procedures on the babies like 1,500 grams, 20, man, come on. You can hit any adult with your eyes closed. I mean, NICU was the best place because by that time I'd done most procedures. But when I get to NICU and I had to do on babies this tiny, oh man, if you can hit a little tiny vessel on a baby, the vein of an adult is like a big tunnel. I'm serious. It's relative. You don't realize your eye, you can see the vein really. Oh, yeah. Nothing to it at all. Anyway, that's just to encourage you guys. Don't run away from codes. Run to as many codes as you can because you get there first, you get to do a bunch of stuff and you get to learn how to do it. Okay. That way, one day when you actually have to put a chest tube in somebody's ICU and the attending says, who's going to put a chest? And you say, I can do it. I've done 3 of them already. So he's impressed that you already know how to do it. All right, put in an art line, put in an IV line, all that. All right, so that's for large objects. Back to us what he talked about. If still unable to dislodge the object, let's say the guy slumps over. Because remember I told you only have a certain amount of time before you pass out. If the person passes out, then you do an emergent cricothyroidotomy. That means you find the Adam's apple. Obviously, it's harder on a female to find a larynx, but you can find it. And then slide right down. There's the wings of, I don't know what the name of that bone is. Anybody know what that is? The one with the wings? Hyoid? That's called hyoid? Yeah. You can feel the wings on it. There's an empty spot right here. There's number cartilage. There's 2 vessels at the far ends, the middle avascular. That's why you feel these come right here with your needle, right in here. You're in the middle. You didn't touch any vessels at all, but now you have an airway. Okay? Cricothyroidotomy. You get in there and they say use a straw that's wrapped in paper or in plastic. That's as sterile as you're going to get. This is how you establish an airway in a restaurant, if you happen to be the doctor there, okay? And put it right in there. You now have an airway till the paramedics get there. Person's life is saved. All right, it's a beautiful moment, folks, when you can save somebody else's life. I've had students in a airplane, like you were talking about. When the airplane is going down, you need a steak knife because it has a sharp point. Because what you're going to do is use wine as anesthesia. Remember, that's what we used to use in the past. And we looking all strange, and they put a little wine on there. That's anesthetic. And then you apply even pressure right in that middle. So you hear till you feel a give. You're now in the trachea. Then you put the straw in there. If you happen to be at 35,000 feet, the plane cannot land in 20 minutes. The patient's gonna be brain dead. So what do? You do the same thing. Get a bottle of wine, right? They sell them on the plane, $4, and they do appreciate exact change. So if you don't have exact change, yeah, I'm a quarter short. Anybody got a quarter? Anybody got a quarter? I need a quarter. Nobody got a quarter in this table? Hey, first class. Anybody got a quarter over there? I mean, I was just playing. But anyway, you buy the wine. That's anesthesia again. Put it on their neck. Take a knife. Oh, wait a minute. We're not allowed to carry knives on the planes no more. No. That steward, what do they call them now? Not steward or stewardess. Airline, what do they call it? Airline attendants. One of them's packing. All right, one of them's got a knife. I'm telling you right now, they're packing. Okay, so you say, I need a knife. And you take the wine, pour it on the tip. That's anesthesia again, and poke it right through. And then you hit the top of the ceiling. Remember, there's plastic tubing up there for the mask. That's sterile. So the tube will fall down. You now have sterile tubing, put right in that hole. You save their life till the plane can land. I had one of my students do that shortly after she was here for a program, and then she told me she was flying or whatever, and then all of a sudden that happened to somebody, and she was the reason the guy was still alive. Okay, but they offered her all kinds of frequent flyer miles. She remembered, turn it down, because you don't know who's related to this guy. Yeah, but it saved the person's life. All right, that's aspiration. Small objects tend to lodge in the right lower lobe. Small objects will fall straight down and go to the right lower lobe. Why the right lower lobe? Cynthia wants to know. That's because it's a larger, and it's straighter. So gravity will pull things straight down there. If you remember, the left goes off on a 90-degree angle. I mean, how's gravity going to do that? So the right mainstem bronchus is wider and straighter than the left. So small objects tend to lodge in the right lower lobe. So anybody who has recurrent right lower lobe pneumonia, they always tell you got a foreign body to deal with. You got to go down there and take a look. And you need bronchoscopy. You go down there, take a look, and pull it out with the same procedure. There's the 3 most common objects to get lodged. Peanuts. This happens a lot in ballparks, as you can tell. Popcorn. Ballparks again. But you know what it is, mom and dad could be eating popcorn at home. A kernel of popcorn falls to the carpet. They don't bend over and pick it up. But then you got a 6 to 9-month-old who's crawling around. He's going to pick that sucker up, put it right in his throat. He has no teeth. He's just going to aspirate it right down. Okay, that's how he became number 2. And then pieces of hot dogs. A lot of parents have a habit of giving those little Vienna sausages to their babies for teething. That's when you're poor, you find a way around it, right? A teething ring may be $3 or $4, but if you're poor in the hood, $3 or $4 is a lot of money. So what they do, little Vienna sausages. It was like a nickel when I was growing up, a nickel. And it had like 6 little sausages in there. You put them in the freezer. When your child's drooling all over the place, he's teething. You put it in his hand. They would do that. That would numb the gum. Teething, taken care of. That's when you cannot afford Ambisol and all the other things that are kind of those are even more expensive. All right, but anyway, that's how hot dogs became number 3. Because one day they actually gum a little piece off of there, and they don't have teeth in yet, and they were just aspirated. Okay. And then finally, dust particles. Dust particles are the tiniest particles, but what they do is divide them into 3 levels: large, medium, and small. Greater than 20 micrometers, large. They get trapped in the mucus in your upper airway, which makes sense because every time you open up your mouth, the wind blows a whole lot of particles into your lungs, but it never make it down to the bottom. Why? Because the mucus traps them. And that's why every now and then, Nolan, what do? You do that. You know what that is? When we do that, all you're doing is popping up the mucus with the debris into your esophagus. That's because when you pull it down to your stomach, stomach acid kills everything. Okay? So, larger objects, mucus. Between 2 and 20 micrometers, cleared by ciliary action. That means it fell down even further to the airway. The cilia would then push it upward, and then the mucus would take it up the rest of the way. And then if it's less than 2 micrometers, the tiniest particles, that's in just about macrophages. And when macrophages ingest this stuff, then they go into the interstitium. This is why anytime you have dust particles, it becomes an interstitial disease. By dust particles, I'm talking about the pneumoconioses, like silicosis, anthracosis. Those are all tiny particles. That's why they all cause interstitial disease, because the macrophages, when they engulf this stuff, they go into the interstitium. Now they're creating a diffusional problem for oxygen. What if they ask you, what's the most beneficial protection for your airway? Cilia. You have cilia all the way down to the terminal bronchioles, so that if anything goes all the way down, yeah, cilia will just bring it back up for you. So if they just say most common or most important, cilia is the answer. But if they tell you what size the dust particle is, now you know how to figure it out. Any questions so far? Evaluation by aspiration, it's called inspiratory expiratory film. We ask you, Halima, take a deep breath in. All the lobes are inflating. Then I say, well, okay, take a deep breath out. I take another x-ray, and I'll notice one lobe never collapsed. That's where your peanut is stuck. Everybody understand? Just only takes a few minutes. And you can diagnose which lobe it is, and then you bronch them and go down and pull that peanut out of there. Now, when something's right along the midline on them, you use what we call rigid bronchoscopy. When it's out to the periphery, you're gonna have to turn some corners, flexible bronchoscopy. Now, only on step 2 and 3 do they want you to know the difference. Step 1 just needs no bronchoscopy. Yes. No, most piece cases is still here in the trachea, but you can see that on the x-ray. Yeah. Yeah, I had one little girl, she aspirated a penny and it got stuck in her glottis. She was still able to talk. That means the penny was just kind of flapping up like that. And so she can still talk, but we had to get it out of there. When you do the x-ray, you can see exactly where it was. So we bronched her, pulled the penny out, and I gave it to Mom. I said, Mom, this is the most expensive penny you'll ever own. I said, because we had to bronch them. That's, anesthesia, pulmonologist, ER visit. That's almost $10,000 for that penny. So it's amazing. Airway anatomical divisions. I gave you a preview already. Dead space goes from your lip to your terminal bronchioles. It cannot exchange oxygen, so we call it dead space. Then the respiratory unit were those other 3 places, which was the respiratory bronchiole, the alveolar duct, the piece that goes into the alveolus, and then alveolus itself. So respiratory unit or alveolar unit is made up of 3 pieces. Okay, that's just an anatomy question. Well, you have dead space ventilation that precedes alveolar ventilation because you have to go through the dead space to get to the alveolar space. You understand that, Anders? You understand, Saba? All right. If you take a shallow breath, you're sacrificing alveolar ventilation, always. All right. And in total ventilation, they made an equation out of it. VD plus VAL. It just means that's when you add them together, that's total ventilation. All right. So total ventilation again. Now we're going to put some numbers on it. Dead space plus alveolar ventilation. And then you can see, well, how much air do you move in 1 minute? That's called minute ventilation. That means your total tidal volume, that means the column that you need, times respiratory rate. So, Maria, minute ventilation, your tidal volume, let's say is 400 cc's, and you're breathing 20 breaths per minute. What's your minute ventilation? What is that? It's 8,000. That's the same thing as 8 liters of air moved per minute. Everybody understand? They'll give you the tidal volumes, give you respiratory rate, you figure out the minute ventilation for anybody. But what they'll do is further tell you how much is in the dead space, and you figure out what the alveolar ventilation is. You just subtract. So, Saba, I got somebody who's tidal volume 500 cc's, and dead space ventilation is 40%. You follow me? Respiratory rate is 10. What's the alveolar ventilation? 40% of 5,000 is what? What's the 40% of 5,000? What's the number? 2,000. Then the remainder is the alveolar ventilation. That means 3,000 is alveolar ventilation. Yeah, so they'll give you all the information you need to figure it out. But either they'll ask you for total, or they'll give you enough information for the total, but tell you what percentage goes to one space and ask you how much goes to the other space. Okay? They're easy if you know the equations. And so I'm giving it to you now so that you understand. This is one equation you got to know. Tidal volume for anybody is calculated now at 6 to 8 cc's per kilogram. They want you to calculate it. Don't put in just some number you got in your training as a resident. That's what, as a resident, they told me put in 500 for everybody. And I saw they do that in so many residencies, just 400 for everybody, 600 for everybody. I say, well, why is everybody the same number? That didn't make any sense to me, but I couldn't get a resident who could explain it to me. They said, we always put in 500. The problem is, what if the person needs 600? Anna, what problem do you see? You're underventilating them. How's that going to affect their PO2? How do you increase O2 without getting the oxygen to the alveolus? Now, you said it right the first time, but you guessed for the second one. No, I said O2. You got it right the first question. That means you understood it. So now apply the same thing for the second one. I said oh hell, I forgot what I said. All right, so 6 to 8, yeah. If somebody needs 600, you only give them 500. That means you're shy of 100. But that's alveolar ventilation. Remember, the end of the tidal volume is the alveolar ventilation. We just went through that a minute ago. Anytime you give somebody a shallow breath, you're sacrificing alveolar ventilation, folks. There should be no guessing. It's always the same answer. You're sacrificing alveolar ventilation. Okay, so that means whatever you didn't give them, you're not blowing up the balloons. That means you're doing the same thing. You're breathing for them, but they're not ventilating. So that's why now there's so many questions where you have to calculate it, because they want to make sure you become a resident who knows how to calculate. Don't just put in 500, because they know that's what residents are going to tell you when you get up there. Yeah, just put in 500. No, don't just put in 500. Calculate it. However, if you got restricted lung disease, as you see here, we go on the lower end, like the jet ventilator. We now know if you got restricted lung disease, the best way to ventilate you need pressure support. BiPAP is the best one. You need a high rate, high oxygen, and now you know tidal volume should be low, but a very high rate, like the jet ventilator. That's what decreased their mortality by 30%. High rate, low volume does better to ventilate somebody with restricted lung disease with minimal trauma. Any questions on that? All right. So there's anatomy of the lungs again. Just remind you, please study this picture so you can visualize all these things. All right, but that's just anatomy. Histology. Let's do histology before we take our break here. We got pneumocytes. There's type 1s and type 2s. Type 1s make up 95% of your pneumocytes, and type 2s are 5%. That's of pneumocytes. Type 1s are mostly macrophages, phagocytes. They're found throughout the airway, but the majority are found in the terminal bronchial. How do I remember that? If you look at the anatomy of your lung, particles will float all the way down and then drop at the terminal bronchial. That's how to remember why smallest particles, i.e. cigarette smoke. Why do you think lung cancer starts there? See, I saw that connection. So, oh, that's why they're always saying that. I never knew till I studied and put it in with the physiology. Now I can see it. All right. So terminal bronchial is where the smallest particles will fall. Okay. That's why it makes sense to have the macrophages there to gobble it up, clean out the airway. The only role that type 1s have in the alveolus, because alveolus dominated by type 2s. The only role type 1s play in the alveolus is to help oxygen get across. Remember, he's diffusion dependent, so it makes sense he needs somebody's help. And that's type 1 pneumocytes. Will carry oxygen across. Type 2s don't do that. Type 2s, most of them are in the alveolus. Makes sense because they produce surfactant. And that's where you need the surfactants, the alveolus. Makes sense, Amy? All right. Remember, type 2s can revert back to being type 1s if you need to clean out the alveolus in any way, or if you need to regenerate the alveolus anyway. So how do I summarize it for students? If there's a question about the alveolus, if it's about oxygen across, I pick type 1s. Anything else, I'm picking type 2s. Make it simple so you don't have to overthink it. Okay? This is a question, and I see alveolus in that vignette. I already know. If it's about oxygen across, I pick type 1s. If it's anything else, just pick type 2s all the time. Okay? But if it's the airway, pick type 1s all the time. When it comes to pneumocytes, that's how I organize it. Again, over 95% accurate, I'll take it. I'll just be wrong a few times. Eric Bouchard, you have a question?
Is it important, Dr. Francis, to know the mechanism that type 1 uses for allowing O2 across, or is that just diffusion?
Yeah, it's just mostly diffusion. Yeah, I've never
Okay.
seen them ask any new mechanism. Yeah, good question. Anna, is this why macrophages carry the most amount of what? Ferritin? Yeah, just not here in the lungs, unless you got heart failure and blood is just in there, then the macrophages are carrying ferritin. But throughout the body too, macrophages carry ferritin because they're the ones destroying the red blood cells in the spleen. So they're carrying the ferritin around with them and they take it back to the bone marrow. Will carrying a ferritin help diffusion? Not that I know of. I mean, ferritin is just iron itself. It's just a storage form. They'll have hemoglobin and the ferritin in the macrophage only if you have heart failure. That means blood is sitting still. Then they have to digest those RBCs for you. Yeah. That's why they call them heart failure cells, just full of iron. Goblet cells produce mucus to trap debris. And as it turns out, Nolan, mucus will move 1 inch per cough. So that means by listening to how you cough, I can tell you where your problem's at. Because again, how you train your senses as a physician, you don't always have to even touch the patient. So when somebody comes in, here's what I watch. I watch how they breathe. If they're spending more time breathing in, where's the problem? Miguel. I don't think he caught it. Edmundo, if you're spending more time breathing in, is that restrictive or obstructive? Restrictive. All you guys do is hear in. That's it. Okay. This person's spending more time breathing in. And here's what you will hear. Watch how I breathe. The person will do this. See how long it's spent breathing in and done with breathing out. That's restrictive. Okay. Prolonged breathing out. Remember, if you read the books, they say prolonged expiratory phase, pursed lips. What is that? That's obstructive. Because now you hear this. See, by pursing your lips, you slow down how fast air leaves. That means you're spending more time in exhalation. That's obstructive. Watch how the person breathes. You can tell. What about when they cough? All right, so when somebody does that, that's they're just clearing their throat. That's sinus drainage. Sinus drainage, gravity's already bringing it down. All you're doing is popping it into your esophagus so you swallow it down. That's what men do. We just swallow everything that comes down. Women are like, yeah, how you do that? Ew. They Kleenex. Ew. Swallow the damn thing, would you? All right, your stomach acid kill everything that comes down anyway. It's just simple germs. All right, so that's when you clear your throat. But when somebody, you quickly count it, about 6 coughs. That's about 6 inches. Oh, bronchi. He has bronchitis. I haven't even talked to him. Haven't touched him yet. Just listen how he coughs. Every time he coughs, you hear about 5, 6, 7 coughs. Yeah, that's 6, 7 inches. It's still bronchus. That's bronchitis. Versus this one. They've changed all kinds of colors already. That's how you know the mucus is way down at the alveolus. You got 30, 40 coughs before you're finally satisfied. Think about a child who has bronchiolitis, because that's the bronchioles way out in the periphery. Or how about somebody with whooping cough? Because the mucus is way out there in the bronchioles. That's why you got to cough 30, 40 times before you get the mucus up. So imagine, therefore, with children with whooping cough, why so many of them used to die. Before the vaccine, folks, 40% of children used to die every year from whooping cough because a baby cannot cough 40 times in a row. It ain't going to happen. It's just in the middle of their coughing. Mucus is coming up. The brain says, hey, you need to inhale. So the baby just forcibly inhales. And that means air comes down like this and meets that pocket of mucus, explodes it like this. And that's why you whoop. And that's how I got his name, whooping cough. Boy, telepertussis. See? So it's so easy in pediatric floor, I could tell somebody who had it because you hear this. I said, whoop, there it is. You know how to take that one, man. That's an old song from way back, boy. Okay, but anyway, that's easy to diagnose. On the test, they'll tell you the person coughs till they vomit. That's because you're trying to breathe while coughing. They vomit. Or they cough and their eyes start tearing. That's because they're trying to keep that pressure coming. And it squeezes tears out of their tear glands. Yeah. Anyway, we'll talk about it under micro again. All right, so smooth muscle is located throughout the entire airway. Most smooth muscle is found in the medium-sized airway. Just like in the blood vessels. Which blood vessels have the most smooth muscle? Cesar. Who? No, aorta has the thickest layer, but that's not what I asked. I asked who has the most? Justin. Who? How do you know it's the arterioles? Because they do the most to regulate your blood pressure. How are you going to regulate blood pressure without smooth muscle? So that's how I remember. Arterioles are medium-sized blood vessels, medium-sized airways. Correlation. Medium-sized airways have the most smooth muscle. What does that tell me? Who regulates airflow the most? See that? Medium-sized airways. Where are you going to find the most bronchoconstriction? Medium-sized. Most bronchodilation? Medium-sized. Where do you find most of your beta-2 receptors? Medium-sized. Where does a child get most of his wheezing from? Medium-sized. See that? But that's their favorite one. Why? Because if you read the book, you look at the book says asthma is reversible small airway disease. You don't really know that small airways in your brain, but it tells you how to know small airways in your brain because that's what you read. But then he'll ask you, well, where's most of the wheezing coming from? You don't realize your brain's gonna be attracted to small airways when it looks down, unless you thought about it and say, oh, no, I gotta pick medium-sized airways because that's where most smooth muscle is found. Yeah, small airways play a role, but that's not where most wheezing is coming from. All right, Clara cells are specialized macrophages. All they do is eat dust. So there's macrophages, phagocytose, dust only. And then cartilage. So we already said you got 16 to 20 C-shaped cartilage rings in the trachea, right down the midline. Once the mainstem bronchus dives into the lung parenchyma, you now have the weight of your lungs on the trachea. I mean, not the trachea, but the mainstem bronchus, you need to have fully encircling cartilage. Otherwise, the weight of the lung would collapse the whole airway. You can't breathe. Now, that's how I remember it, so I don't just memorize it, all right? Once the mainstem bronchus dives into the lung parenchyma, that means into the lung tissue, the weight of the lung is now sitting on all these bronchioles. You got to have cartilage all the way around so to hold it open. If you don't have enough cartilage to hold it open in a newborn baby, that's called laryngotracheomalacia. That means soft cartilage. They'll have severe stridor for about 18 months. You just got to wait till the cartilage calcifies. So this baby does a lot of stridor whenever you lay him down on his back, because then the airway just collapses because he doesn't have the cartilage to keep it open anymore. But they're real noisy breathers. All right. Epithelium. The upper 1/3 of your trachea has squamous cells. Remember why squamous cell carcinoma is the most common intrathoracic cancer? Right here. Middle 1/3 of trachea is a combination of squamous and columnar. Then after that is all columnar. Pseudostratified because it comes down, narrows at the waist, and then goes back out to normal. So it looks like it's two cells stacked on top of each other, but it's not. That's what pseudostratified means. So tall columnar, pseudostratified, and ciliated epithelium is the respiratory epithelium. Sounds like a long title till you visualize it, then it's easy to remember. The more you smoke, the longer the zone of squamous cells, because smoke is an irritant edema. And if you irritate cells, they're going to mutate into another adult cell type that can handle that stress. What do we call that? What's the term we use for that? Yeah, metaplasia. And that's why all of a sudden now you have more trachea with squamous cells, and therefore you get squamous cell carcinoma. And what's the hormone that squamous cell carcinoma produces when you get in your lungs? Melissa. That's right. Ashley, you know this one? What's the hormone associated with squamous cell carcinoma of the lung? PTH. Remember, hypercalcemia is your clue. She said what? Why'd you say it so softly? I can't even hear. Oh, just in case you're wrong. I don't know why you guys are so scared. Okay, as soon as you guys find out you're right, then I hear you guys loud and clear. Man, come on, I keep telling you guys, say it loud and clear. That way, if you're right, you get a lot of points in the mind of the attending. If you whisper and then you find out you're right, he doesn't give you any points for it because he knows that's why students whisper, because you're afraid to be wrong. That's how he knows he thinks you're guessing. Don't do that. Don't take points away from yourself. All right, so anyway, that's the respiratory epithelium. And then how do you help somebody stop smoking? Well, if I can help you stop smoking, it turns out after 5 years, your lung parenchyma will go back to normal, but cancer risk stays the same. After 10 years of not smoking, cancer risk is cut in half. And after 15 years, cancer risk is back down to 1 to 3%. So you can erase all the damage done by smoking. That's why we try to get people to stop smoking. The other reason is because smoking is the #1 risk factor for all diseases in America. The one modifiable risk factor for disease in America is to smoke. And you go connect to over 60% of cancers, heart disease, lung disease, I mean, renal disease, stroke, my goodness, it's everywhere. So that's why we try to help you stop smoking. The best one is nicotine patch. Nicotine patch is the best one. For test questions, nicotine patch is the best one. Why? Because it comes with a support group. If you like Alcoholics Anonymous, why they're so successful? Support group. Remember, empathy is so powerful. People who've gone through the same thing you've gone through. When somebody can say that to you, it's powerful. And then because they're calling you every day, giving you, sending you nice positive text messages, all that, that helps a person feel that they're being encouraged. And so they're more likely to succeed. So nicotine patch is #1. Bupropion, #2. What's the bad side effect with bupropion, Miguel? And Ida. And Angie. Seizures, remember seizure risk. So anybody with a history of seizures or any risk of seizures, so electrolyte disorders, if they're on diuretics, bulimia, anorexia, we don't give it because they're gonna have a seizure one day. And then varenicline is #3. Chantix. Varenicline. Varenicline is a nicotinic receptor agonist. So it's giving you the same buzz as the nicotine that you get a buzz from. And then you slowly wean it down. Varenicline. Chantix now has a support group because they were trying to compete with nicotine patch. Yes, sir. How did this get bumped down to #3? It got bumped down to #3 because the initial studies, retrospective studies they did showed an increased incidence of homicide and suicide. Nicotine, pushing a sympathetic tone, makes you angry. So they were committing suicide or homicide. Now, when they went back and reviewed it, after they got more data, it showed that the risk of suicide or homicide was the same with all the drugs. So they took the black box warning off of it. So the problem is, once you get that reputation, it's hard to scrub it off yet. Yeah, I'm not using that. Any doctor use it, hey, that's up to you if you're brave enough to go ahead. Because if your patient is the one who's unfortunate commit suicide or go out and kill somebody, a good lawyer is going to try to get you for it. And say it's because of that drug and cite all the old studies, and it'd be hard to fight that in court. Yes.
With like the increase in vaping.
With increase in vaping?
I know it's very new thing right now.
Yeah.
But what we expect to see questions on it, it's so new.
Yeah, the only thing you want to know about vaping is a good question. Is it EVALI, e-cigarettes and vaping, acute lung injury. Yeah, so it's a severe lung disease, restricted lung disease seen with e-cigarette users and vaping. And it has to do with the chemicals they use. They don't expect you to know what the chemicals are and all that, but they do expect you to know that disease. Okay, all you can do is just like ARD, put them on steroids and hope for the best. Has a high death rate, just like ARDS. All right. Anyway, let's stop smoking. And then final one here, we'll do cilia and take our break here. Cilia line the entire airway all the way down to the respiratory bronchial. They beat in one direction towards your mouth. We use that word orad, means towards your mouth, oral. It has a 9+2 configuration. That means 9 microtubules surrounded by 2 actin proteins. Do you know of a microtubule inhibitor that we've learned about, Nate? Been who? Been blasting. Edna. Colchicine. Gloria. Been Christine. All right, so we've learned a few of them. All right, so anyway, any of those microtubule inhibitors obviously are going to mess up your ciliary action. So people who are on those drugs have more pulmonary infections, obviously. Okay, but then cilia need a dining arm, remember D for derriere, to move backwards. Because what they do is, if you watch my arm, the cilia beat in one direction towards your mouth that way. They beat that way. Then they come down out of the mucus, slide underneath the mucus. See, they're going backwards. That's why dining. Go backwards and go back up in the mucus. That way mucus only moves in one direction. Otherwise, if you accidentally pick the answer that says cilia beat back and forth, then that means mucus is not moving. So be careful. It moves orad. It does not beat backwards. It's passive movement going backwards. When dining is broken, what disease is that? Ida? Huh? Cartaginers. Cartaginers, see that? Obstructive lung disease, look at that, bronchiectasis. Now you don't even have to memorize that. That's what all obstructions die from. Because you got mucus that won't move, that's an airway problem, obstructive lung disease. Everything we already learned about obstructive applies. Saves you a ton of reading. But there's your triad. Bronchiectasis, infertility, because of cilia in the fallopian tube, cilia in the epididymis for a male. In fact, for men, remember cystic fibrosis? They actually obliterate their entire vas deferens. And so almost 100% sterility for men. Not quite as bad here, but they're a high infertility rate. And in sinus inversus, remember, which part of the GI tract must undergo this counterclockwise spin coming into the abdominal cavity? Cynthia. It's not the midgut, is it? Are you asking me a question or are you answering my question? Okay, she doesn't remember. Angie, what are you saying? So kind of, you're asking me a question again? I asked you first. Why do you guys always ask me a question? I don't want a question. I asked you a question. Give me an answer. Nolan. It's the midgut. Thank you, Nolan. That's right, Miss Cynthia. I don't know why you guys punish yourselves so much. Keep telling you guys, just answer the question. Because when you're asking the question back, it means you don't know that's the answer. I told you that technic's not going to give you credit if you're right. It's still because you sound like you're guessing. So he's not going to give you any credit. So that's why I'm trying to help you form these habits now before you leave here. Because when you go on rotations, folks, you got to know the perception of the attending based on what you said. To get maximum points, just answer with confidence. Why? Because you know you're going to be right the majority of the times. Not because anybody's right all the time. But if you're going to be right the majority of the time, just say it with strength and confidence. They love that. Okay? All right. Sinus inversus. Only the midgut develops out in the yolk sac. And then it's got to go that 270-degree counterclockwise turn coming on in. Okay? And I think that, yeah, that's a good place to stop. And then we're going through lung sounds after the break. So start back at 2:35, 2:35, sorry, 10:35. Dang. Folks start packing their bags.